Hedging phrases for medical abstracts. Avoid overclaiming. Welcome! Today we're talking about how and why to hedge your conclusions, especially useful in medical and scientific writing. Hedging helps you avoid overclaiming from limited data, so readers don't think your pilot study proves more than it actually can. A careful tone also builds credibility. Reviewers and colleagues trust authors who recognize uncertainty and boundaries. Finally, hedging matches the norms of medical journals, where precision and caution are part of clear, ethical communication. By the end of this micro-lesson, you'll know exactly how to strike the right balance between clarity and caution. Hedging means expressing results with measured certainty, not hiding them. You report your findings clearly, but you soften absolute claims to reflect the limits of your evidence. Instead of stating truth as final, you signal probability, acknowledging that additional data may refine the estimate. Practically, hedging uses modal verbs like may or could, adverbs like possibly or likely, and phrases like the data suggest or it appears. The goal is transparency. Be honest about what the study shows, and equally honest about what it cannot establish yet. Use modals to show possibility. May, might, and could suggest that an effect is plausible without asserting certainty. For observational signals, appears to and seems to indicate careful interpretation of what you observed, not proof of mechanism. To grade confidence, add likely or possibly. It is likely that adherence improved, versus it is possibly related to baseline differences. Combine them thoughtfully. The intervention may reduce readmissions and appears to benefit high-risk patients. Each phrase fine-tunes your level of confidence. Choose verbs that reflect evidence strength. Prefer suggests over proves when data are preliminary. The analysis suggests a dose-response pattern. Use indicates rather than demonstrates for cautious interpretation. Our model indicates improved survival at 90 days. When you can't claim causation, write is associated with instead of causes. Higher sodium intake is associated with elevated blood pressure. These verbs keep conclusions accurate, respectful of study design, and aligned with peer review expectations. Don't hedge vaguely. Tie caution to numbers. Anchor claims to confidence intervals, p-values, and effect sizes. Risk ratio 1.30, 95% CI 1.05 to 1.62. Use calibrated language and ranges. A modest increase in response, a small effect on A1C. Replace fuzzy words like significant with specifics. Absolute difference 4.2%. 95%, CI 0.8 to 7.6. P equals 0.02. When readers see the magnitude and precision, your hedge becomes informative, not evasive, and your conclusions become both cautious and actionable. Increase caution when your evidence is less stable. Small samples or wide confidence intervals mean estimates may shift with more data. Observational or single-center studies are vulnerable to confounding and limited generalizability, so avoid causal language. Be extra careful with secondary outcomes or subgroup analyses, which are more exploratory and often underpowered. In these cases, emphasize uncertainty. Findings should be interpreted cautiously and require replication. This signals rigor while keeping the door open for future confirmation. You can safely reduce hedging while staying precise when evidence is stronger. Look for consistent results across methods or datasets, which boost credibility. Pre-registered, adequately powered trials with low risk of bias justify firmer wording. Strong effect sizes with narrow confidence intervals support clearer claims about direction and magnitude. Even then, avoid absolutes. Prefer. The intervention likely improves outcomes across settings over the intervention works everywhere. Strong evidence merits confident, not absolute, language. Use templates that balance clarity and caution. Our findings suggest that early follow-up may be associated with lower readmissions. The observed improvement warrants further investigation in larger, multi-center trials. Causal inference is limited by residual confounding and single-center design. Mix and match. Our findings suggest that telemonitoring may reduce emergency visits. However, causal inference is limited by adherence variability. This signal warrants further investigation. These phrases make your conclusion professional, transparent, and journal-ready.